Thanks for all coming out on a summer Wednesday morning. Before I begin, I do have a couple conflict of interest worth disclosing. I do receive in-kind support from a few device companies. However, I do have agreements such that I have academic independence with all the data that I collect. I will also be showing photos and videos of kids with their parents' consent largely, some adults with their consent. They are not for redistribution that is not already approved, if you don't mind not taking photos of the slides with faces. Thank you. The University of Calgary, where I work, is located in the traditional territories of the peoples of the Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, Piikani and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation within Alberta, including the Nose Hill Métis and the Elbow Métis of District 6. I gather we're in unceded territory of the and please, I did look it up, but correct me if I am less familiar with these First Nation groups. Musqueam, Squamish, and Tsleil-Waututh, thank you. In the spirit of reconciliation, I am to learn a little more about what unceded mean, because it is much less common, I gather, in Alberta than it is about 95% of the land in BC, I learned. And I gather it represents that settlers largely occupy the lands now, but there's no formal agreement about the land, about the governance, or the shared responsibilities. So that having looked that up makes a lot more sense. Some of the news I've been reading, and I imagine is everyone's lived reality here. I have 5 objectives, which is a bit bonkers for a talk of this length, but I will keep each one of them very short, I promise. One, briefly to discuss the long-term impacts of neurodevelopmental disorders causing mobility impairments, the most common of which is cerebral palsy, but I find too much of our education and our literature focuses on cerebral palsy. It is easier to study one more predefined thing, and there are many people who are rare groups who are left out. If the commonality is a mobility impairment, for instance, maybe we should include that because the impacts are similar, and we can be a little more mindful of when to include and exclude. I'm going to critique the roles and practicalities of interdisciplinary supports for youth with neurodevelopmental disorders causing physical disabilities as they transition to adult roles, to adult services, and adult healthcare. Really, I'm going to give an example of what we're doing, part of which I think is actually quite good. I'm going to explain a role for power training in youth with cerebral palsy, and hope that you are able to do the same afterwards, that you will be able to understand the opportunities and challenges associated with marker-based and markerless motion analysis. I know people here have been dabbling as well, and really question, what can we do so that we really can generate clinically meaningful, not just group level information. And then assess the potential for innovative walking aids. It's probably the biggest focus of some of my research, using them for often habilitation, but also rehabilitation, as well as an assisted device. So just some questions. What we know about adults with mobility impairments are largely adults with CP. So are there more kids or adults living with CP in Canada? Yeah. So I'm going to get Tim to monitor the chat. You guys can give a thumbs up if it's an adult, and clap if it's, I'm trying to think of other gestures. I saw a few thumbs up. Yeah, it is by far, there are more adults living with CP in Canada than there are kids. In fact, 75% of people with CP are adults. 85% of people with CP live into adulthood. There are often not the services for them. Do the symptoms of cerebral palsy get worse? Again, we'll give thumbs up for yes and clap or other gesture on Zoom for no. I got 1 thumbs up in the room, 2 or 3. Yeah, so even, this is not surprising in this audience, people are aware, even though the definition is that the injury to the brain in people with CP is non-progressive, often the symptoms and how they manifest does get worse throughout adulthood. In fact, about 50% of young adults will have a significant decline in their gross motor function. Hand function and communication abilities often decline a little bit later in middle age. And if we think of that gross motor function classification system, the GMFCS, a 5-level ordinal scale, many people drop a full level on that in adulthood. And by the time they're 45, about half of people have dropped. By the time they're 65, 90% of people have dropped a full level. So we need to start doing better. This might be a little tricky for a pediatric audience, but so far you guys have been rocking. Go ahead and shout it out. Name a couple health conditions that people with CP are greater risk for developing, not including sort of lifelong impairments that are like hemiparesis or spasticity that are due to the CP itself or the musculoskeletal impairments. What are other health conditions that people with cerebral palsy are at high risk of developing as an adult? Respiratory conditions, yes.
Paul says cervical myelopathy.
Cervical myelopathy, yes. You got
conditions? Broad category.
Yeah, really high rates of reflux, really high rates of constipation, absolutely.
Osteoporosis.
Osteoporosis, yeah. So loss of abilities may indicate a new musculoskeletal or neurologic condition. And in my care of adults with CP, I often see patients who, unfortunately, for a year or two, have been told it's just their CP. And we pick up the cervical myelopathy, and they often become permanent functional declines. I have 3 in my relatively small practice. I see adults 2 half days a month who have permanent declines due to untreated cervical myelopathy. The other ones that I was unaware of until a couple of years ago is that dementia is more common in people who did not have significant cognitive impairment as youth among people with CP, as are psychotic mental illnesses. Osteoporosis and many of the other musculoskeletal things are well expected. The other thing we now know is that many young adults with CP develop type 2 diabetes, hypertension, ischemic heart disease, strokes, and other chronic medical conditions at high rates in early ages. And so why am I telling you guys this? Well, these are the people you're seeing, these kids on the screen and teens. They're going to grow up, it's permanent, and they are at risk for many things. What do we do about it? Multidisciplinary care is recommended in adulthood and in pediatrics and at the time of transition. So I'm going to talk about a few things and why I think they might help the trajectory along the way. So starting into the first one, transition to adult roles and services. What do you guys do here for transition to adult services? Do you have a multidisciplinary service to see adults and or youth in transition? Is that no? Sort of. Okay. My next question was going to be what services are involved, and maybe that sort of will address it.
Paul says there is the GF Strong Adolescent and Young Adult Clinic. It sees ages 12 to 24.
Okay. And who all is involved in that clinic? Is it just a physician?
There's PT, OT, and a teacher.
Okay. So there is multiple disciplines. So at Alberta Children's Hospital, we do some of it well and some of it we're desperately working on to improve, or there's a clear need to improve. The part we do well is the part that's served by the Youth Functional Independence Clinic. It serves youth with a physical difference that impacts their daily life, that have goals related to living independently or competitive employment. The clinic was actually started out of a philanthropic donation trying to address a need, particularly because in Alberta, if you're over 18 with they call it pervasive developmental disability. Essentially, if your IQ is less than 70, you are eligible for funding, particularly if you do have some impairments in adaptive functioning for this PDD program, where there are programs in the community that can support with sometimes competitive employment or independent volunteerism or supported employment or supported volunteerism. There are day programs and a spectrum of services for that group. But we also know the group with the goals related to living independently and competitive employment often move out later. They get driver's licenses later, they get post-secondary degrees later and at lower rates, and they get employment later and at lower rates. So we're striving to work on this, as well as to decrease the consequences from risky behaviors. Sex, drugs, and medical non-adherence is another common one, which I'm sure you're all aware of among teens with chronic medical conditions. And youth with disabilities are known to participate in risky behaviors at much higher rates than even the general adolescent population. So we work on medical self-management. Do they know their diagnosis? It's been really interesting to me. I often start, and so, you know, tell me about your health. And I've had a number of people who say, you know, my leg doesn't work very well. Do you know why? Do you know what it's called? And these are cognitively strong 17-year-olds who don't. Their families were told when they were 1. And they have not wanted to focus on it. There's many different philosophies I've heard. I've seen some really embarrassed parents when I ask this question. I've also had patients tell me that they can't have sexual activity because their brain has already exploded, and it would explode again. It's really interesting and makes it a really rewarding clinic when you can explain that these things are options for you. We try to make sure they know their rationale for management, and also try and make sure that we know their transition plans. It has been quite humbling when a nurse is not in clinic with me, how hard it is for me to figure it out. And I have access to all the records, let alone the family who's like, what do we do, when, where? We do disclosure of the health information and the varying degrees of disclosure in medical education, vocational, and truly public settings. What do you not need to do, and what are also just some practical approaches when you have a visible difference? Talking about decision-making spectrum, community mobility, including driving. Alberta is an interesting situation where the driver has to report their medical conditions, not necessarily the medical providers. What is it in BC? If someone has a medical condition that may impact driving, is it their responsibility or your responsibility to report it?
The physicians.
Yeah. That's where in Ontario, where I did med school, it was. I think it's just 2 provinces where it's actually on the patient's responsibility. We still have to give them the guidance and set up the spinner knobs or however else, left foot accelerators, etc. Talking about post-secondary education, career planning, household management, including cooking. Really, the OT often is the major driver of this clinic. Other goals related to independence in daily life. Sounds like you don't have a lot of services. If you could add one discipline to your care of transitioning youth, what would it be? Yeah. Social work, absolutely. I have found, just by how we were set up, that a really good anyone who is informed by other people and is willing to talk to other people works really well. But a true clinic coordinator, and I don't mean that in any disrespect for the nurse who's been serving our clinic coordinator role, or the OTs who've stepped in, or I've stepped in a couple times now, that really is any training, but a passion for the population, and who can get information from the key social worker or whoever else, is what I find is most helpful. If I could add anyone to the Youth Functional Independence Clinic, I'd add a patient advocate. It's happened organically a few times, and people learn from peers so much more or faster and with greater trust for the information than they do from me. Okay, shifting gears. What else can we do? Really trying to tap into some of those issues related to some of the secondary health conditions that were probably related to, or at least in part related to, the decreases in physical activity that we see. Power training. Are you guys familiar with this picture I've got on the right? I see some nods. Yeah, so strength training has a nice big green bubble. It is something we should be doing. Is it available here? If you see a patient with physical impairments due to a brain-based disorder, can you prescribe an intensive strength training program that happens 3 to 4 times a week? Once a week even? Yeah, that's what the same boat we were in. We know we should do this. We can't do this. when you look at the details within strength training, the person who really was angered by the fact that she joined our clinic and couldn't find any way to access strength training was one of the physiotherapists, and she did a bit of a deeper dive. The types of strength training: power training, which really addresses weakness at the speeds that are required for physical activity. Most strength training focuses on slower speeds, or traditional strength training, and that's not actually how we move in daily life. Power training is having a moment across the media. I feel like I probably don't need to spend as much time on it as I did a couple of years ago, but it involves moving at high loads at high speeds. We know it can improve the sensory motor control using magnetoencephalography. A group in the US has seen that in use of cerebral palsy specifically. Similarly, we know that people with CP or other types of spastic muscles have changes in their muscle architecture. Not only are they smaller and stiffer, they have more electrocellular matrix, they have more fatty infiltrates, the sarcomeres are at a rest stretching length, and you can improve this muscle architecture with power training. So you're improving the original problem in the brain, you're improving where you manifest it often in the muscle and the control between. Interestingly, someone also showed you could improve arterial stiffness, which is an early marker often seen in teens of cardiovascular disease. So it's evidence-based to improve motor function. It does fabulous things for the underlying physiology, which we think will have lasting, lifelong effects and address some of those issues we had in adulthood. Why isn't power training part of standard of care?
Or can't access it?
Yeah, why can't we make it accessible? Funding, yeah. So it costs money to have a program. Why can't they just go to the gym?
I feel like they need special, like someone with special training and like exactly the right power training.
Yeah, so most of the literature is actually done at clinical centers. And so you have to be close enough to come to the clinical center or research settings. We have discovered, we partnered with some community gyms that were providing gym experiences, adapted gym experiences. And even then we have found that our physiotherapists that go to the gym have to help support the fidelity. There are fabulous, passionate people about being inclusive and promoting, but you still need someone with a clinical confidence to say, no, this is okay, we can do this, and to make the adaptations so that they can say that at times. So one of our physiotherapists, Candice Natrasini, took an implementation science course. She was so frustrated by the fact we didn't have one. She truly took an implementation science course and created a program out of her learnings from it. We offer power training in a group setting, but it's an individualized program that is based on their goals and set by the physiotherapist. It's delivered individually, and actually sometimes it's 2-on-1 because we're also trying to build capacity and knowledge. And so we have athletic trainers, kinesiologists, and a lot of students. So each youth has 2 trainers, and that way if a trainer doesn't come one day, they still have at least one. We do it at community fitness centers, so you don't have to be just next to the children's hospital. And we do it 1 hour, 2 times a week for 12 weeks. It is a little less intensive than most of the programs have been, but when our Candice was going through and doing some focus groups, many of the families said 3 days a week is too much. We can't juggle it. So we do 2 days a week. She does send a home program. The adherence to that program is highly variable. This is one of the examples of the functional tasks. So not only are we doing traditional gym things, but here you go. This young man's goal was to wheel faster. And so he did a lot of training of the relevant musculature, but then you also train the functional task so that you get the carryover. We know that strength training can be very task specific unless you pair it with functional task training as well. And so there is time spent on both activities. This is a lot of data. Don't worry too much about it. The left panels show the individual dots before and after training. You can see in general, the lines are going up, scores are getting better. The right panels actually show you the change scores. And essentially what we found was significant changes with large effect sizes in all except our 1-minute walk test in this cohort. In our larger cohort, we've now confirmed that that is significant. So clearly we're causing functional, and sorry, I didn't belabor the point. The COPM, these scores are this Canadian Occupational Performance Measure. So we're evaluating the family and child's goals. Whenever possible, it's the child's goals. But the families are part of it. And then to get a little more objective measure, because that ends up being a ranking, which has a lot of bias. Are you really going to tell a physiotherapist that you worked hard for 12 weeks and you didn't feel any better? We don't remind them of their baseline score, but there is a potential for bias there. So we use the goal attainment scale, where we take a couple of their goals and we pair it with an objective measure. So if you want to be able to walk to the corner store and not be so tired that you have to take the bus home after hanging out with your friends, which was one of the goals, we did a 6-minute walk test for that one. And so we try to pair it with an objective measure that we know what changes. And then with the goal attainment scale, if you move up, essentially, it means you are meeting your expected change. So it gets converted to a T-score, and we had significant change there. Gait speed, 1-minute walk test, and muscle power sprint test is that last one, which can be done if you're using a wheelchair. We also did some qualitative research, and sometimes I think this is, we need the hard data to convince anyone we're trying to get funding from, but this is sometimes really meaningful. I felt more confident when I was doing things, said one youth. Parent noticed he stands taller. These are things it's really hard to measure confidence, but we've heard it time and time again. Other quotes about, doing it in this way, a parent said it's just way better here. The fact that we're running it in a community program, they're training around the other athletes or general individuals who go to the gym. Another parent said they could see, oh yeah, okay, I'm part of a group of regular people that go to the gym. And it has changed some people's identity that they can be a regular person who goes to the gym. There were barriers we weren't fully anticipating. Another parent said this is the beginning, not the end. And in fact, a few of our alumni trained together. They've hired a personal trainer. And so now they just have one personal trainer to the group of them, but they train together just to maintain the benefits once a week. So power training, we can offer an evidence-based intervention that impacts underlying physiology in a less resource-intensive way. Stay tuned. We are launching a project now to develop an implementation kit to support the spread and scale of this program, because right now you're really stuck to an urban center where you have access to a subspecialist physiotherapist. And so we're working on the tech side for some remote monitoring of velocity with the equipment, so that you don't even need to be where there's necessarily a subspecialty or a pediatric physiotherapist in the vicinity. Can we get a physiotherapist to support in a small community? Could we get a trainer working with a physiotherapist virtually to support this and have remote monitoring? And also there are other cities that have pediatric physiotherapists. Can we help you start programs? We're working on it. Shifting gears a little bit, I know this is close to someone's heart in the room. How many of you are involved in instrumented gait analysis? We got a couple. Okay. So why do we bother? Mobility is consistently, when people rank priorities, children with mobility impairments, adults with mobility impairments, and families of children with mobility impairments all list maintaining mobility, keeping up with friends, and less fatigue or pain while walking as among their top priorities. We know instrumented gait analysis can be used to guide interventions, and we know it can also evaluate interventions when we're trying to decide for an individual who's going better or when we're trying to set policies. And it's now being used to predict outcomes, which really can help inform your conversation. Do you want to do this intensive thing to get a 20% improvement on the thing you've told us you've cared about? Is really what's starting to come out, which is really neat. So we know we can do it and it's really helpful, but it's not easy. Sometimes children don't walk the way they usually walk. You bring them into a gait lab, you make them stand still with a stranger touching them. We had one child come in recently who got very nervous because she thought we were going to touch her privates. because understandably, she had been told not to let anyone roll their pants down. But we need to get at the anterior superior iliac spines on the pelvis. We had to roll it down. Fortunately, we figured it out before we did anything, had a conversation. We are not touching your privates. But it's known as the Hawthorne effect. Everyone doesn't quite walk their usual way when they know they're walking, and everything we do to increase the awareness of that you're being watched increases a little bit how abnormally you walk. Marker-based assessments also add a lot of time. You need a specialized person to put on those markers. The children have to change their clothes, and some people have refused entirely for religious or other reasons. We also know that children with mobility impairments have generally poor body image esteem anyways, and we are now drawing attention to that. Sometimes the cognitive and behavioral requirements of standing still or not pulling off your markers, or the sensory piece of having markers on are a problem. And sometimes we don't get good data because markers are obscured, for example, if they're using a gait aid, a walker, things like that. So markerless motion analysis can be done. I just have these dancing kids here to see. You can see it's tracking their skeletons pretty accurately as they have a good time. Do you think it can be used in their own clothing? Do we need to get kids to dress like they're in the lab, or can we have them just walk in, dance around for a bit, and maybe at some point we've just got the cameras on, they'll walk in a normal way and we can get that data? I guess we'll go thumbs up for yes and clap or other gesture for no. Okay, everyone's really positive. So here, what we did is we had people do it the conventional way, shirts rolled up, taped up, markers on, etc. But we recorded the markerless data. And then we looked to see if we got different answers when we just let them wear their own clothing. And so we looked at what's known as the root mean square deviation across all 3 planes and 4 lower extremity joints of motion that we usually track. And generally just the test retest reliability of putting markers on and then putting them on another day. It varies by joint, but about 5 degrees for an average is considered. So we're below that threshold in the sagittal and frontal planes at all the joints, but the transverse plane is a whole nother kettle of fish. And the pelvis looks like it's lower, but we're actually not tracking much motion at all there. So another way to look at it. So interestingly, these 2 people had good data despite this clothing. However, when we did our root mean square deviations, we went and looked for these people who are outliers. So yeah, it did a really good job here, but what were these outliers wearing? Could we find a pattern that predicted? So if an individual had an outlier at any plane or any joint across the combination, they were labeled an outlier, and we tried to eliminate whatever they were wearing that could have contributed. And so while this person on the lower right panel did not have any outliers, we actually would not recommend someone come in wearing that because we did get outliers. So using that process, we did find if people wear close fitting but comfortable their own clothing, if they have a shirt that extends below their hips, we need to tuck it in because that seemed to create a lot of outliers. And if they have shorts or pants that go below the ankle, that don't have a cuff coming narrow at the ankle, we need to roll it up or sort of tape it down so that the ankle is fine. With those limits, they can wear their own clothes, but some of the other options that are super loose, or the one on the right, her skirt wasn't a problem, but her pants that went down to her heel were the problem. It's actually my child. I came down to see how the assessment was going, and she was on the head of my graduate student. What about the issue with obstructions? So here we have in the solid line, the markerless assessment, and the dotted line, the marker-based assessment. The 2 colors are the 2 legs, just looking at the knee angle of someone walking in this walker. They walked about 30 passes, and we got 4 passes that we were able to track the marker-based assessment. But when we looked at our markerless assessment for those 4, we got a lot more that we had solutions for. But if we looked at the marker-based for those 4, we matched really well. So I think this suggests there are people we can't currently answer questions for that we are going to be able to answer questions for. So I appreciate all your guys' optimism that we can let them wear their own clothing and that we can use it to improve care. I sort of put an ish on that. There are some restrictions on the clothing they can wear, and we have to keep in mind that we may not trust the transverse plane yet, but there are lots of questions we can ask with the other information, and we can expand the population that we are thinking of informing care with from the gait assessments. Okay, everyone's still with me. Hopefully we're going on to our last topic. Why innovative walking aids? I used to call it robotic walking aids, and then someone came out with a device, actually two of the devices on the screen, there are debates of whether they're considered robotic. And by some definitions, they're all robotic, and some definitions, the levity in the middle that doesn't have an active motor might not be considered a robotic. And some definitions, even the Agilic on the right, which has an active motor at the knee, some might not consider robotic. I forget why right now. So we're just going to call them innovative. It's new stuff that's not covered yet. The technology seems to be spitting out really fast right now. 6 years ago, there was one innovative walking aid available in Canada. Now there are lots. The two in the bottom left are not available in Canada. Everything else on this screen is available in Canada. In general, what we're looking at is what I consider three types of classes of devices. The group on the left provide postural support and leg movement to facilitate walking for those who cannot walk. The middle device provides body weight support and stability, which can potentially support the development walking or support walking in those with significant difficulties. And the group on the right generally assist or resist motion at a single joint. Most of them were designed originally to facilitate active physiotherapy sessions, but in their assist mode, people have started using them in daily life. More similar to some of the devices in adults, such as like the Kyogo or the C-brace. There are definitely lots more. I am mindful I'm in Vancouver. Does anyone here have experience with X-Motion or the Mogo? They're adult devices, but they are designed and really championed here. Okay, how might innovative walking aid impact a child with mobility impairments? And I want you to think in two categories, and maybe ideally we'll come up with a short list of things that help with rehabilitation or habilitation. And by that, I mean a process that enables a person to develop a skill or ability that they don't currently have. And that's where the debate of rehabilitation is they had before, and habilitation is they may not have had it before, which is a lot of pediatric rehab. It does not require ongoing use. And I didn't mean to make that a bigger font. It's kind of funny that it is, but it's emphasized. It doesn't require ongoing use of the strategy or of the device. So you do it for a while and you have this skill that you have moving forward. Assisted device is items that ease the strain of daily activity and that require the device to continue to ease the strain of that daily activity. So let's start there with an assisted device. How might an innovative walking aid impact a child with mobility impairments as an assisted device?
Facilitate more independence.
Yeah. There's a potential that it could facilitate more independence. Everyone wants that, and not all devices do that.
Extend, like the example of the child wanting to be able to walk home from the store, like extend their ability.
Yes. Go farther, longer, less fatigue. Yes. One of the adults who uses the Trexo, which was on the left there, her favorite thing to do is to go into a coffee shop with her friends and order a coffee standing up. That is absolutely inclusive participation.
Help with bowels.
Yes. Bowel function often improves. We know this. If we have a patient who comes in and they're in bed for a long time, bowel function gets bad, or even if they have limited mobility and they're sitting, bowel function is worse. The pumping of the legs helps with bowel function. If we can support mobility and the physical activity from it, we can improve bowel function. Well, let's move on to rehab. Can any of these devices cause a lasting benefit that will persist after the device isn't used anymore? I see a pretty firm shake no. Anyone want to argue with that? Ooh, I do. I'll show you some of our own data with the Trexo, because I think that's often where people are definitely not. And I have to admit, that's where I started based on other evidence. It is an evidence-informed opinion. Things have shifted a lot in the last 5 years. There's a systematic review released, I think, in April of exoskeletons for use of cerebral palsy. And there is clear evidence now that they can be used to improve motor function. Gait specifically, there is less clear evidence around balance. I think the devil's in the details, which device used how, which population, etc. But here's a little video of what some of the families have perceived. Whoops, try that again.
Letty started with the Trexo when Letty actually was recovering from a double osteotomy hip surgery.
We are coming 3 days a week, almost 45 minutes to 1 hour walking, and he loves being upright and roam around and meeting people. We are seeing more strength going on in his muscles, and we hit maximum of like 3,500 steps on a single day. It's very amazing experience.
Originally, we were looking just for the physical side of things to see what her strength was going to be. What we found was Letty all of a sudden started talking, playing games with her brother and sister, and actually wanting to interact. The research is absolutely life-changing.
So you saw there that when the child was coming around the corner, there was an adult turning it. The Trexo, in my mind, doesn't really facilitate independence, because even when I'm in it, I need someone to turn it for me. I'm a relatively small human and I can fit, but I still can't turn it. But on the other hand, I can walk in it, and if you cannot walk, you can experience walking. In terms of its use as a rehabilitation tool, we did a study where we lent it to families for 12 weeks. We asked them to use it quite intensively, 150 minutes a week. Most didn't meet that target, so you don't have to use it that intensively to get this results. Each dot represents an individual, and these are their change scores at 4 weeks, 8 weeks, and 12 weeks into the intervention, and then followed up 4 weeks, 8 weeks, 12 weeks later. The box plots show you the line in the middle is the median, which by 4 weeks, there was about no change. And after 8 weeks, there was a change, and that change, in fact, was significant. And it wasn't just still significant, it was built upon at 12 weeks, but it was of similar effect 12 weeks after the intervention ended as it was at the end of the 12-week intervention. So for the population of kids who cannot walk independently, a device that facilitates, in my theory, it's the dynamic upright mobility that is causing a repeated high-intensity postural challenge. It is resulting in improvements in head control. What does this mean to the families when we talk to them? Things like voluntarily controlling their head to turn toward interesting things in using their wheelchair in their usual environment. It could be supporting their trunk when someone's helping them put their pants on. They don't need someone else supporting their trunk, or independently transferring to a toilet. I talked to one family, true story. She had really bad back pain. Her child was 8, kept getting heavier, and had never done an independent transfer to the toilet until after 4 weeks of using innovative walking aid. So I've started to not shake my head quite so vehemently. No. As an assisted device, I think exercise. So we heard about bowel function. I think exercise is one of the big functions. Many people, especially the population who has unable to walk, have difficulty with other voluntary movement and have difficulty getting their heart rates up in exercise. We showed that with the Trexo, about half the group can get to the moderate to vigorous range, and everyone else is able to achieve light physical activity. We've done some further research and realized you can actually do things to promote more physical activity. So if you've got someone who's only getting light, you pump up the speed, their physical activity goes higher. If you have someone who does no stepping at all, you may be challenged to do a 30-minute treatment session, probably because you're hitting that vigorous physical activity line as soon as you start. And so maybe you want to dial down the speed if you want a high number duration of intervention. But if you were going after the physical activity and you just want your 10-minute burst, 10-minute bursts, you'll get there. We also saw what I call impacts on the sequelae of inactivity. We know that if you're inactive, you're less likely to have positive mood, you get constipated, and you have poor sleep. And across an observational study where families who bought a device just sent us reported data, across our interventional studies and across a few other modes, sleep consistently improves. Every study I've done, sleep improves. The other two sort of depend on the study. The other two are also really hard to measure in this population, and often the families tell us they don't like our questionnaires, and we haven't found one that understandably represents well. Physical activity scales often ask about sweating, and families say, you know, that's not how my child functions. They sweat for other reasons, things like that. From the qualitative data, what we heard about, they noticed improvements. So in interviews afterwards, in gait, postural control, quite a few families all just commented freely on that. We weren't asking specifically. Standing, but a few people mentioned crawling, appetite, bowel function, head control transfers. We were asking about, or we pulled out for this figure any comments they made about physical function. In terms of quotes, people said, it's strengthening in her quads and in her core have been huge. It just makes her life easier. And, you know, the pure scientist in me is like, well, we didn't measure her core strength. But the family is attributing that her life, they see her life as easier, and they notice that it seems to be due to strength. I've never seen him sleep better. He goes to bed without fighting and falls asleep very fast. I didn't think to measure sleep in our first study. It was the family who told me, oh, sleep got better. And so we've measured it ever since. And that is by far one of the most impactful things many families say. Any of you can imagine when many children are awake at night, so are the families. He's just hungry and needs to eat what's in front of him, too. Eating is just more and eating better. He hadn't needed to use any PEG laxative for the whole time that we had the Trexo. It's not a direct quote that we put here, but every single one of our families mentioned it was meaningful to be able to walk holding their child's hand. So back to those inclusion participation goals. So we've now run trials in our hospital setting, in our school, or not our school. We do have a Gordon Townsend school for kids who need intensive rehab about during the school year, and we've run some there, but we've also lent devices to schools or lent devices to families who take them to schools. We've used them in home communities, and the devices can facilitate walking for those who cannot walk and have lasting improvements in postural control. We've also heard a fair bit, you know, back to that question of what can it do? Consistently in family enjoyment of the walking, family enjoyment of the different social interactions with the public. Instead of, there seems to be a recurring theme of instead of being pitied when people see you, people are interested and they ask about other aspects of life too in a more interested, respectful way. Families are enjoying the physical activity, and there are other more individualized benefits for each child. We're currently running trials to evaluate the impact of devices for people with less motor impairments. Some of these other devices on the screens, I just don't have results for you yet. And we're exploring approaches to reduce the barriers to implementation, because it's one thing to stand up here and talk about these fabulous devices, but I'd be very remiss to not comment that they are expensive. Now, the one in the middle is actually comparable to the price of a Rift and Pacer, which many of our families have, but it's not currently covered by the system that buys the Rift and Pacer in Alberta. I gather it is in Ontario. So there are barriers related to cost, but even when we take the cost barrier away and we lend it to a family, you know, the Trexo is a big device, and transporting it and the child's wheelchair, even if you have a wheelchair van, is fine if you don't have any other children. But what if you have other children and you need all the seats in the van? There are all sorts of issues related to that. And so I have a grant right now where we've been conducting questionnaires, and based on that, we're setting up a lending hub. So we're hoping to set it up to facilitate use through a lending hub in the next year. Okay. Just to review, way back to the beginning, I started with the doom and gloom that there are many health conditions that people with neurodevelopmental disorders causing mobility impairments face that really impact our adults at even higher, or we pick them up later. We talked a little bit about some of the multidisciplinary care that can help support transition. And what I didn't necessarily say explicitly, but there is some evidence to suggest that if we can support earlier and successful engagement in post-secondary and vocational activities, volunteerism, et cetera, we can also support physical activity. And there is a tie between the physical and the secondary health conditions. It isn't perfect. We are quite convinced that even when correcting for the physical activity difference, some of the cardiovascular differences, at least in cerebral palsy, still exist. And there's a growing theory that maybe there are common genetic risk factors for premature birth that are a vascular risk factor that may put you at risk for other vascular disorders, including the high rates of renal failure and cardiovascular disease, et cetera. Power training absolutely can improve motor function. It is a great way to do that. You can help youth meet their goals through it. And we can figure out ways to do it more sustainably so that we can have problems to follow the big green light of what we should be doing. Markerless motion analysis can answer some, but not all clinical questions now. The models are getting better every year, so we may get that transverse plane, the global we as in humans, and AI may get that transverse plane figured out. But for now, it's some clinical questions, but there are lots of clinical questions. You know, what is the impact if I put Botox in the quads? Does that actually help this stiff knee gait? Because am I going to repeat it many years knowing that every time I do it, I get a little more contracture in that muscle? But if they're able to stretch and use that muscle so much more, it's probably worth it. So it can answer some clinical questions, and it can expand the population for whom have their care informed by this powerful, I think of it as an imaging modality. And innovative walking aids can result in lasting improvements in motor function and can serve as an assistive device. Obviously, none of this work is done alone. We have some fabulous team members. We've had incredible participants, including all of those who've agreed to have their faces shown today, as well as patient partners and a lived experience and group that informs everything that my lab does, as well as project-specific partners that I've highlighted here for the projects that we're discussing, and some great collaborators, funding, community partners. And with that, I'd be happy to take any questions.